Hello, everyone, and welcome to tonight's webinar. My name is Eric Hughes, and I'm the product manager for osteogenics. Before we get started, let me address how we will be interacting tonight. From a technical perspective, we can't hear or see you, but we would love to hear from you and be able to answer any questions that you may have. There's a Q&A button on the right-hand side of your screen where you can type your questions at any time, and we will get them answered during the end of the webinar. Now I'd like to introduce our presenter. Dr. Tamir Wardani has dedicated the past 17 years to extensive training in dental implant surgery and its associated procedures, which include complex bone augmentation and sinus augmentation. After completing dental school in Tennessee in 2004, Dr. Wardani completed a fellowship in implant dentistry through State University of New York at Stony Brook. Dr. Wardani then continued his training in Europe alongside some of the world's leaders in implant surgical procedures and guided bone regeneration. This extensive training guided Dr. Wardani's concepts and techniques of advanced bone augmentations, such as complex horizontal and vertical ridge augmentation, vestibular reconstruction, and compromised site development for future implant placement. He lectures extensively on bone regeneration and has been consultant with the Department of Tissue Regeneration at Stanford University. In 2017, Dr. Wardani started a referral-based practice in Northern California focused solely on hard and soft tissue regeneration, implant placement, and implant revision surgery. Dr. Wardani, welcome tonight. Thanks for spending your evening with us, and we're excited to hear this presentation.
Thank you, Eric. I appreciate it. I want to first thank Osteogenics for having me on here tonight. You, Eric, my local rep out here, Darren Young, always does a great job with all the region out here, helping us out, getting us connected with all the products. Shane, Blake, everybody back in Texas, just thanks a lot for having me out here today. Today, I'm talking about something I'm really passionate about. The topic is innovations in horizontal ridge augmentation, utilizing PTFE, dense PTFE, in a bit of a unique way to get us the results we want without the risks that we don't want. And this is a topic that's very passionate to me, so I hope everybody enjoys, and any questions, we'll go to that at the end here. I hate to start off by bringing everybody's mood down here. I just finished my day of surgeries here, and this is what I deal with. This is my everyday. This was really the start of my passion with bone regeneration. Was started off placing implants just like we all do, Eric, and then we start transitioning into a phase where we see these implants fail, and implants that we thought went in with no issues, we thought went in perfectly healthy, perfect dimensions of bone, ended up like this years later. We can see these x-rays from implants that fail. These are all my implants, early on, and I still get failures till today. But, these are the implants that we see that really changed my mindset. And as time has gone on, we know the rates of implant failures have increased, and it increased for many different reasons, but we know these rates have increased. So to me, it's a paradigm shift that needs to be accepted, that we have to first focus on regeneration and building a foundation before we put the cart before the horse and place the implants. And I think that's something that's missed quite a bit in today's implant world. When we look at the studies out there, this is a great Homley Wang study out of Michigan, that showed the different reasons why implants failed. And we're not going to go into these all today, but, I want to just highlight that, there's keratinized tissue issues, soft tissue factors, implant positioning factors, clinician factors. But really, he came out of this meta-analysis study looking at the fact that the implant was placed in a too buccal of a position. Now, this doesn't necessarily mean that every clinician was blind and placed the implant too close to them on placement. No, it also means that the implant was placed too close to that cortical plate, and that causes issues. Danny Boozer out of Switzerland that's done just immense studies on this topic. We know that there's going to be a two-directional blood supply going to the bone and just creating an osteointegrated site here. And that's going to come from the periosteum and the endosteum. But what we see very often is that if we are placing that implant with not enough of a buccal bone or a grafted bone, we get a suffocation of that cortical plate. And that leads to a dying off or a necrosis of that buccal plate that leads to the issues we see very often. So it became my destiny, my passion, my lifelong just journey to create situations where we can graft predictably, utilizing the knowledge that has been given to us by the grandfathers, the Shanks, the Luzadas, Urban, Jovanovich, everybody coming in with just such great knowledge and such great history of how bone regeneration is perfected. But I wanted to take that to create a technique, to create my own vision of what works in my hands and what is most predictable. And that's really what we're going to talk about today, is how we take ridges that are thin and resorbed. We get so many patients that have not had teeth in so many years. Those ridges resorb. We know that vertically, horizontally, and we get these excellent results that we see here. We can take knife edge ridges with very little trabecular bone within, and we can get this excellent, robust bone result that we see here in a fashion that is very predictable. Again, we're going from a knife edge ridge to something that we can feel very confident placing our implants in, knowing that it's not only going to support the implants, but also going to support the soft tissue, and which is also incredibly crucial to the longevity of these implants. Now, I'm talking today a lot about PTFE, dense PTFE. This is very important to us, but how do we use it? We can use it in many different ways. So briefly, just going back on the history of PTFE, it was Roy Plunkett back in the 30s, 1938. The guy's just trying to figure out a way to invent a better coolant, a gas coolant, and he leaves the batch out overnight, comes back in the morning, and finds this polymerized, slippery, waxy solid with these great properties that ends up being used for a myriad of different things. And then he passes the baton to Gore, Robert Gore, and he takes over in 1968, kind of literally stretches out this material and creates essentially the Gore-Tex material. And he took that into the medical field, creating these Gore-Tex ePTFE type of membranes that were used in tissue regeneration and early guided bone regeneration. But then where things really just got excellent for us in a way that we can now utilize it predictably in our practices in so many ways. Barry Bartee, 1997, patents this material that it has a smaller porosity to it. Those early ePTFE membranes were great. They isolated the soft tissue, as we all know, but they also allowed a transition and a transfer of the microbes and the bacteria to the graft site, resulting in a lot of infections and failures of the grafts. So when Bartee gets this dense PTFE with a smaller micropore size, it still gets us this excellent quality where we can isolate the soft tissue, facilitating cellular adhesion and still creating an environment that doesn't allow the bacteria to really transfer into our graft site. Not only that, but now it allows us to leave this exposed, and that became a game changer. Now we can leave this membrane exposed and use it in non-augmentive procedures. This is my everyday, everything I'm talking about today, this is my day-to-day practice here. This is all I do, is bone regeneration all day long. But this is my simple bread and butter. You know, no matter how many ridge augmentations we do, the bread and butter is still going to be your socket graft, your patient that's got the fractured endo tooth and comes in. We got to take that tooth out. We make a little envelope space, buccal and lingual, and then we're going to tuck that PTFE membrane in. Usually I tuck it in lingual first, unless there's a buccal defect, then I tuck it in buccal first, and then we suture over that. Very straightforward. We've seen this time and time again. Put a couple of sutures over. Those sutures really, in my opinion, don't do a whole lot, because it's really the tucking of the membrane that is creating that, allowing that membrane to stay in place for those 3, 4, 5 weeks. But we put those sutures over it anyway, so the Patient doesn't blame us for the membrane coming out too soon. So we put those sutures in, and then we come back in and we take that membrane out and we get this nice, clean, still immature osteoid layer of bone starting to form internally and underneath that. And very quickly, we're going to get that soft tissue, nice transfer over the site and end up placing an implant in about 4 months. So this is just beautiful use of a dense PTFE membrane. This is my day-to-day activity with this membrane. Now, what about sockets with defects? Again, one of my major things that I preach in my courses is if we have a defect, it's important to visualize that defect perfectly. If we cannot see the defect, we're going to miss it. We're not going to be able to manage that defect correctly. So we're going to elevate a flap. Usually in these flaps, I am not making any vertical release. I am simply making a sulcular incision 1 to 2 teeth down so that I can mobilize the flap, so I can mobilize the tissue to really get down to the apical portion of that defect. And that's something, again, I preach. If we cannot advance the flap beyond the most apical portion of the defect, then we're going to miss something. Or when I place that flap coronally again, it's going to push the membrane coronally up with it, creating a space that's not covered by the membrane I'm about to place. And that could allow soft tissue invasion into my graft site. Anytime I'm looking at a defect, I'm always being very cognizant of Joe Kahn's studies that really highlight the fact that it's not so much the length of the defect that is that crucial. We can have a defect that's very long, but as long as it's not too wide mesiodistally, then we can manage it very effectively. Once that defect does become a bit on the wider side, now we have to think in terms of how are we going to manage this? This is more than a basic repair. We might go into the augmentative realm as we're trying to figure this out. So I like to do this. I like to take the RTM membrane. I don't use a lot of cross-linked membranes, but I do like the RTM membrane from Osteogenics because I love the fact that it's not going to resorb too quickly. It is cross-linked. And when I'm trying to line the defect, I place that RTM horizontally at least 3 millimeters distal and mesial so that I can really get horizontal. I'm creating a cage. I'm creating a barrier at the defect and then over that barrier, because I don't like to place collagen over the crest exposed. I don't like to leave a collagen membrane exposed. If I'm going to leave something exposed, it's going to be that dense PTFE membrane that I love so much. So we're going to take that membrane and place the bone. We're going to put our allograft here, and then we are going to cover, just like now we transfer back into the realm of the basic ridge pres, basic socket preservation, and we're going to suture up just like I would the basic socket pres, just with a few more sutures where I've made that sulcular incision. And we're going to come back again and we're going to take that membrane out in 4 to 5 weeks, let it heal. And at 4 months, you see in the x-ray, we've got great bone. We've got excellent bone. We've managed the defect using that RTM collagen. We've placed the PTFE membrane over it so that we can leave it exposed. When we leave collagen exposed, it just creates a little ditch. There are certain collagens out there that create more of a volume effect, but I don't like to leave just thin collagen membranes exposed. So we're putting this, we take it out, and we get great results managing defects, great long-term results, great bone quality from Encore bone we're using. Nice allograft, really works out so well for us. This is what we like to see at 5 years. We like to see that nice bone still crawling over the collar of the implant. And we just go through a couple of quick videos here. We can see we've got a fractured tooth here. We're going to go ahead and take that tooth out. We're always going to make sure we know where the defect is. Like I said, biggest mistake I see is that that defect is not identified. And when it's not identified, you try to just treat it like a basic ridge pres. And I've seen time and time again cases sent to my office for larger augmentations that could have been managed so simply early on if the defect was just identified and managed at the time of extraction and at the time of the initial graft. Okay, for this, now that I have a larger defect, Now, sometimes I am going to make a little vertical incision. We learn from Urban, we always want to bevel that incision right at the zone of the mucogingival junction and the keratinized tissue. We like to bevel that incision so we can put it back together like a puzzle piece, but we can see that defect now. We can really curette it out. Sometimes I sit there with my assistants for 10, 15 minutes, really curetting the site out. We've got to have a nice platform, a really nice clean zone to place our bone. Because sometimes we go back, we blame our failures on the membrane, we blame the failures on the bone we used, but sometimes it's our own failures for not just cleaning out the area, irrigating it. I like to use in an infected site, I like to use a doxycycline slurry. I take a doxycycline 100 capsule, mix it with some sterile saline, and really irrigate that area before I'm going to put my bone graft in. But here we come. Now we're going to swipe in with that RTM membrane. This is our barrier. This is our cage. This is our protection. This is what's going to stay in there because we're going to take that PTFE out early at 4 or 5 weeks. But I want something that's going to resorb a little slower for that zone until the bone catches up with its ossification process. So we see that nicely there. It's backwards here. I usually put the bone in after I put that cage in. After I put the membrane in, then I put the bone. Videos just showing it the other way around here. But really nice combination of a mineralized, demineralized graft here, putting that in there. And then we just place that membrane. We trim this almost teardrop shape. So the wider portion is at the apical portion. So it really covers that defect. And then we're going to drape it over just like we do any socket graft again. The end result looks like our basic ridge preservation here. And we'll come back in 4 or 5 weeks, take this out, and you can see the x-ray there. That's following 4 months of healing. We get excellent results. So you see how d-PTFE can be used in these more basic situations where we're not augmenting, but this material becomes just a great magic act for us to be able to get nice results from our grafts. So what about when there is horizontal resorption, when there is a healed ridge, when teeth have been extracted for years and we get this resorbed ridge? What techniques are out there right now? Because everything I do, and I use every technique. I've used a lot of techniques, but everything I do is based on the literature and based on techniques that have been done before my time, or during my time, I should say. I studied under Istvan Urban in Europe. I spent a lot of time with Istvan. Such a wealth of knowledge. This guy's a groundbreaker. And what we see is that he came up with the sausage technique. Excellent technique here, utilizing tacks. These are Meissner tacks and a collagen membrane, a native collagen membrane. And the nice thing about this is that you have that native collagen membrane that allows this transvascularization from the periosteum into the graft. You also have a situation where nothing's really going to get exposed because it's all collagen. This is excellent. But this also comes with its own challenges. Again, this is nice results. This is one of our cases right here you're looking at now. We put this in, different tack system. We did a horizontal augmentation on the upper right posterior with an associated lateral sinus lift. And we get beautiful, look at these results. These are just nice results we can get when it works. The problem in everything I'm saying, I'm talking about my own issues here. I like to talk about things from my end and my failures here. Sometimes it's not as easy to get all those tacks in that it requires to get that membrane secure. We're banging on the patient. We're coming in from the lingual. Sometimes it's on the mandible. Patient's got a big tongue. Patient can't keep his tongue still. Patient's sedated, and we're trying to manage the sedation alongside of placing these tacks on the lingual. This can get very technique sensitive, even for the best of us. And, if I'm the only one, then fine. But it gets very technique sensitive, trying to get the amount of tacks needed to be able to get a healthy, good sausage graft in terms of the result. So what other techniques are there out there? Well, I've used titanium mesh. I love titanium mesh. Also a very nice technique. The nice thing about tie mesh, usually I'll just use this in verticals. or a combination vertical horizontal. The nice thing about titanium mesh that I do like is that it heals well initially, and if the titanium does become exposed, which it does, some literature shows that it's going to become exposed almost 50% of the time. Well, now we have to babysit it. Now patients coming back every few weeks. We're checking it, making sure there's no infections. But I will give it a nod that you get a layer of what they call pseudoperiosteum that's going to form beneath that or underneath the membrane, to where if we do have to remove this, we can still get a decent result. This almost looks like alfalfa's hair, but you almost get a decent result here. We still get it, but then we close this back up, we let it mature a little bit, and we can come back in and place some implants and really get a nice result. So yeah, a little more expensive, especially if it's a custom made titanium mesh, that does run your cost up quite a bit. You really have to charge the patient for that. And a little more technique sensitive as well. Not so bad on getting the screws through it to secure it, but it can, cause some headaches through the process. So what else is out there? What other techniques can we use? Well, here we go. We know that titanium reinforced d-PTFE has been used in GBR for quite some time. And I will tell you what, when we get a nice result using reinforced PTFE, and I say this honestly, I think these are the best results. When you have a case of horizontal or vertical augmentation using a reinforced PTFE, the cases come out beautifully. That's going to require excellent immobilization of the membrane. It's going to involve having screws, Profix screws or tacks, placing those buccal and lingual as well. It's making sure that we've got a patient that's a healthy patient. It's going to make sure that our soft tissue biotype is not too thin, because I tell you what, if we have a very thin biotype, the chances of that membrane becoming exposed really increases quite a bit. So we see that. That's the one downside, is these membranes do become exposed sometimes. Doesn't mean they're a bad membrane, but it's something that we have to manage. We have to understand that with the benefits come the risks of what we have to understand is coming. Now, what I really like, what I use more often than this nowadays, and I love, is the RPM membrane. This is now titanium reinforced d-PTFE, but with larger perforations. And those perforations, to me, allow more transvascularization of the soft tissue. It allows more cellular adhesion to the overlying periosteum to minimize the chance of exposures a bit more. And I get really nice results with the RPM membranes, mostly on vertical augmentations. We put that over there. I like to use a collagen type of, almost like an alloderm type situation, or a collagen type of something to create some soft tissue thickness, a protective mechanism over that membrane when I'm placing it, just to create more soft tissue thickness. And we see the results at 4 weeks where we get nice closure. We've got that transvascularization going through that RPM into the graft. Now, you're going to notice this is an interesting case because it did start to become exposed. These membranes just can become exposed. Maybe some mobility. Maybe I didn't secure it well enough, but we got a little exposure here at the facial. You can see that right there, right next to number 27. Now, we didn't go in and take this out right then, but we managed it. Now we gotta go into that babysitting mode where we see the patient over and over again, making sure that this situation doesn't become too advanced. Now, here we started to open it up because it did become more exposed than I like to see at 15 weeks. But because that RPM allowed that transvascularization to come through, in my opinion, those larger pores, we still were able to get a nice result. We're taking out the RPM now. We're still a little early. We're not ready to place implants here. We're going to go in. We're just going to cover this with a collagen membrane, let it sleep for another 3 months, and then we're going to go back and place our implants. We get nice results here. We get beautiful results from that type of case. But once again, great membrane, but we still got to be able to manage it the way we need to manage it. Very important that we manage this correctly. What about a more complex situation? This is one of these situations where I call the referring dentist. Referring dentist says, hey, my patient wants to save these implants. I call the referring dentist back, say, hey, I want to take these implants out. But financial reasons, emotional reasons, this was a situation where patients just said, "Hey, doc, can you please try to graft over this? Can you please try to save these implants?" So we did. We don't have all the photos of this case. We went over this with a tie reinforced PTFE that you can see there. Now, one thing on these cases, and I just because I'm using this case, I want to digress and really make you cognizant of one of my trickiest areas that I work with is the lower anterior. Maybe it's just me, but this is an area that I find very tricky. When you're looking at the depth of that sublingual crescent, the floor of the mouth, if that depth is somewhat shallow, you're going to have problems because no matter how much you fixate that membrane, now, when you fixate that membrane well, it's definitely going to help out. But that mobility from talking, from chewing, from the patient moving their tongue around, that mobility, because of such a shallow sublingual area, shallow floor of the mouth, tends to want to really open that flap up, and it becomes very challenging. And that was a situation here. We see it opened up now. It opened up in a somewhat of a clean way. We actually babysat this for almost 6 weeks. We babysat this. Patient coming back and forth. By the time this patient and I are done, I've seen him so much, I'm going out to dinner with the guy. So we really see the patient quite a bit, in these times to make sure they don't become more and more exposed. But finally, it got to a point, started looking really crummy, a lot of plaque buildup, a lot of that microbial buildup around it. So we took it out and we really got a nice result here. So we can manage exposures, and we can do a whole nother lecture on managing exposures, but we really have to be cognizant of what is coming to us to be able to manage this correctly. And we got a pretty decent result down the road here when we went in to place these implants, and months down the road there on the cross section on the right. So when we are looking at the different techniques that we use, we haven't talked about the Corey technique, using a bone plate. I don't do a lot of Corey plates, not because they don't work. I think they work great. That's really using autogenous bone as a bone plate and putting autogenous bone particles within. But I'll tell you what, there's a lot of times I don't want to take a block graft. I don't want to take a plate and saw it in half. Sometimes that takes a little more time, even though the procedure tends to be not as long. But there's a lot of risks in that. Sometimes we don't want to do that on a daily basis. So really, as we move forward here, I want to talk about what the two crucial components are in any large augmentation when we start now going to our innovative technique. I want to just look at this very quickly. I divide these factors that help our grafts out, into activating factors and facilitating components. When I talk about activating factors, I'm talking about autogenous bone. One thing Istvan taught me a lot was, hey, you use autogenous bone, and now it becomes just second nature. And the gurus of GBR were really big on using autogenous bone because we know all the growth factors that are harvested even in those cortical shavings of autogenous bone. What about the endosteum? Why do we perforate? Why do we make these perforations? We make these perforations because we want to release the growth factors from within the bone. We want to release the growth factors from within the endosteum into our graft. We're having it come into the graft to help us out. That's very important to us. What about PDGF? It can also help. BMP2, we use infuse every now and then as well. PRF, PRP, we use that. I don't think it's a game changer, but I like to use it in my larger grafts. I feel like I get nicer healing, some good results using PRF. I have nothing against it. I'll tell you, vitamin D is that unsung hero. When I have my patients, I do a lot of blood work on my patients before larger grafts. When I see their vitamin D levels over about that level of 35, I see wonderful results. After COVID, you saw a lot of patients getting weekly injections of vitamin D, 50,000 milligrams I use of vitamin D weekly. And the grafts I would do on those patients just really were just catapulted to just better levels. So I really like the effects. I have all my patients on 5,000 units of vitamin D, unless their physician says otherwise, starting months before the graft, or leading up to it. What are the facilitating components? Also, patient's health. We're very detailed about whether the patient's a diabetic, a smoker. I'm not taking risks on large grafts. These grafts are too technique sensitive already. The last thing I need is the patient's health working against me. So I urge all of you to be very critical about the patient's health. Sometimes there are times where just the implant is not the best option. The graft is not the best option. I'm sorry, as much as we love to place grafts and place implants, sometimes the patient just has to go with a partial denture because their diabetes, for example, is out of control. And we have to be cognizant of that. It's not just about, hey, I'm going to have them sign a consent form and whatever will be, will be. Kind of be ethical, be responsible with your patients, making sure that we're getting a good result and you don't need the headache of the failures that come with that. And our biomaterials, are we going to use allografts, xenografts? And I'll go through that on what we're going to use with the cases to come. So we're going to go through that. Again, autogenous bone shavings, we really like to harvest on almost, even on immediate implants, we harvest autogenous bone to mix with the bone we're going to place into the gap. I harvest autogenous bone on almost 65% of all my cases, including some ridge preservation grafts. So we really want to go to that external oblique line, kind of holding that scraper at a 40 to 6-degree angle. If you hold that scraper too parallel to the bone, it actually makes it tougher to scrape the bone. So I like to hold it at an angle. So you really have to go down to that external oblique line just to get the great results you want. You want to get those great shavings into your graft. Now, I said there were two factors. Our first factor, we're really having something to turn on the graft. We needed something to turn on the graft. Those are those activating factors. I like to say we can't just use boxed bone. We got to turn on the graft. In a socket, that's turning on the graft because when you take out a tooth, you have excellent healing faculties right at that moment. That's where you have the height of growth factors coming. But when we don't have that socket, we got to inject something in there, whether it's making cortical perforations, whether it's harvesting autogenous bone, whether it's, using some other kind of growth factor. We got to do something to turn the graft on. Well, what's the second factor? The second factor is we got to get some fixation. We have to have all those techniques I mentioned have fixation. That's what makes them work so well. So we cannot bypass that. And I stress this because early in my career, and I know there's clinicians out there, they come to my lectures and they say, why can't we just lay a collagen membrane over when we're doing a horizontal augmentation? I say it's not going to work. And if you look at this Ronald Young study out of Switzerland, out of Zurich, so one of my favorite studies, basically what he did in a nutshell, he takes patients and is doing the augmentation chair side, doing horizontal augmentation chair side. And he's dividing these into patient groups where some have fixation and some do not have fixation. Okay. So he's measuring the amount of horizontal bone he grafts and then suturing up and comparing that to the measurement he gets off the 3D image that he walks the patient back to take. So he's taken a CBCT 3D image of that patient immediately after suturing. And what he found was that there was almost a 25% decrease in the group that did not have apical fixation, almost a 25% decrease of bone volume just from the time that the patient was sutured to the time they walked back to the frickin' CBCT. That's incredible to me. So it really harps the point that you have to have some kind of apical fixation to be able to help this horizontal graft work. So when I'm envisioning in my mind and I'm thinking, okay, what's my graft? What are the factors here? I've got the endosteal growth factors in zone 1. I'm getting those out because I'm perforating the cortical plate. Then I've got zone 2 where I've got some kind of membrane, a native collagen membrane maybe. I like that transvascularization that comes through a native collagen membrane. I really like the healing of that. I've got some kind of a bone substitute with some autogenous bone, maybe some PRF in there as well. But I've got growth factors in that boxed bone as well. And then I've got those periosteal growth factors coming from the other direction. So you can really see the three-dimensional activity of a graft that makes it work. Okay, if you're skipping some of these, they're not going to work all the time. So now we're going to go. So what can we do now? We mentioned all those techniques, and you kind of read between the lines that I'm a little, hesitant. There's complications that come out of some of those. How can we make our cases more predictable? When a general dentist is doing a crown preparation, you might have to go back to the lab back and forth for a fit, but for the most part, it's going to be okay. We need to think in the same way. We have to think horizontally in our horizontal bone volumes that this can't be a 50-50 proposition. We've got to think that we can do this predictably all the time, because the other factor, my friends, is that if we don't, we're not going to do it. We're going to avoid it, and we're going to end up making mistakes like placing the implant into too thin of a bone ridge. We're going to end up placing the implant in the wrong prosthetic position. We have to place our implants in a prosthetically driven position also, because those occlusal factors are going to help us later on down the road to the help of this implant. So I just became a search for me. Every time I'd be in the car, what can I do? What can we do to make this more predictable? And then I stumbled across this study. And, I'm sure we were probably figuring this out at the same time. They just beat me to it. Our work is still in publishing right now. But this is a sling case. This was on an edentulous case. The study was done on edentulous patients using a PTFE membrane in a fashion that is supported apically. They're putting Profix screws or tacks in here, supporting it, but not lapping that PTFE over the crest to the lingual to where you're going to have exposure. So this really just rang in my head. So I said, okay, how can I take this idea and really create something that's going to be predictable for me? So I went to the patient. No, I didn't go to the patient right away. I'm not going to experiment on the patient. So I did not do that. I'm joking with you. So what I did, I like to order pig jaws to the house. This is how I enhance my skills. This is how I test new techniques. So we went ahead and ordered some pig jaws to the office, and I took the PTFE membrane. I wanted to see how this was going to work. And we went ahead and put some Profix screws in, great 3mm Profix screws. I really only use the 5mm Profix screws when I'm doing some kind of tie mesh, but these are the 3mm Profix screws. I cut the PTFE out of the way. I don't want any of the PTFE touching the adjacent teeth. We know that. And I'm placing the PTFE in a manner that it's apical enough to really house the bone, but also not too apical. And now this allows us a basket to really condense that bone. And then I said, okay, we're going to place a collagen membrane over this. And I'm going to skip that part, but we place a collagen membrane over that. And then we go to our technique. So this is what it's going to look like as we move forward here, placing the Profix screws, putting that d-PTFE in place. This is our basket. This is our bone net where we can now really condense the hell out of that bone. And by condensing that bone very well in that apical basket, it's also creating some form of retention, some form of immobility of that particulate bone. Okay, and we're going to suture it down, put that membrane over it. I like to do some periosteal sutures here, but let's really now dive into this study that we created. And we collect data in our office. This is an office where we take techniques, we take materials, we take biomaterials, and we test them out. We want to see what works and what doesn't work. It's not the blind leading the blind here. We want to understand what makes sense and what doesn't make sense. So when we put these bone net test guidelines together, we said, okay, what can we take from the techniques that have been tried and true? And how can we transition it to techniques that we're trying out here? So we wanted to do a technique where we didn't have to make 2 vertical incisions. Typically, I'll only make 1 vertical incision of the flap. Why? Because 2 vertical incisions, that's going to cut off the blood supply more than I'd like. So we just try to do 1 vertical incision as much as possible. There are times where I'm not getting the flap mobility I'd like, and I do make 2 vertical incisions, mesial and distal. Okay, we're going to place that d-PTFE membrane fixated with screws, with Profix screws, always using the Profix screws. And the other thing here is with some of those other techniques, you're tapping, you're banging, you're doing that. I don't like doing that. So I love the Profix screws because it's easy on the patient. I have my assistant just give them a little jaw support. We screw that in. It's so much easier to get out, easier to put in. I just like the Profix screws a lot more than banging on the patient. We're going to use larger decortications. I tend to decorticate right before I place my graft, because what you'll see is you'll decorticate early on in the procedure. By the time you come back in to place the graft, it's dried up a little bit. So I like to decorticate right away. That's when you see that heme coming out of the interior of the bone there. We're using 25% allograft. We're using 25% xenograft. We want that allograft to turn over quick and get the process going. We want that xenograft to hold its form stability. And we want the autogenous bone to really activate that graft. I try to use up to 50%. It's not always the case, but I try to get up to 50%, sometimes even 60%. We're going to put a native collagen membrane over the crest. Something's got to go over the crest. So since we're not putting the PTFE over the crest, we're going to put a native collagen membrane over the crest. And then I am going to try to cinch the membrane down. You know, that rib roast technique that we know about, phenodontics. You know, we're going to put that rib roast technique. We're going to go ahead and try to cinch that down. Some periosteal sutures with the glycolon sutures. I love the glycolon sutures. They're going to resorb, but they're not going to resorb too fast. So that's really good to leave internally. And then we're going to work on healthy patients. Like I said, I'm not going to beat that into the ground, but we want healthy patients that we're working on. This was our first case. We placed the bone, we placed the membrane, we placed the collagen. We had collagen placed on one side, PTFE placed on the other side. We sutured up here. There we go. We sutured up and we came back in 6 months. Now, I'm going to show you what we saw. Look at this excellent bone. Yeah, it's a little soft there, but we really had a nice result here. I'd say this is some of the just really nicer results we see. But now I'm going to pull out. You see the cross section of the bone we got here. Now look what we got. Look at the area that was covered with the PTFE. You can see that. You can see it so clearly versus the area that was collagen only. Look, this was somewhat of a complication because I had to go back in and regraft that area as I'm placing these implants. But at the same time, for me, this was proof of concept here that look what that PTFE is doing. Look at the magic of that PTFE. Look at the soft tissue isolation of the area where the PTFE is versus the area where there is no PTFE. Now, we just cut it short. We made that mistake, our first case. Now we're going to move forward with this and really take this to town and see some very nice results here. Again, we're going to get a couple of double slides there. Sorry about that. So we're going to move forward here. We got great results on that first case and 3-year follow-up study on that case now. Here we go again. We got this resorbed ridge. We got an extraction along with it here. We're going to put that PTFE in place. Those Profix screws go in so easily. Just make sure you have your assistant holding the patient's head still so they're not, working with you. They want them to work against you a little bit. We're going to put that screw in and really fixate that PTFE in place. Now, when they have that 2 screws in, when you've got those screws in, it really allows us to pack the bone. I am not lightly packing here. I am packing this bone in place so that the bone at this point essentially holds itself into place because of that excellent apical support that we are getting. And that's really helping us out here, being able to just layer this bone on, stack it into place, get that bone in place, and just get us this nice cone shape appearance. Now, what I like to call this is this condensed bone contour. We take CBCTs on these patients right after the graft. If you see this nice contour, these are the cases that became a success to us. These were the cases that were working with us, not the cases where there was more of a diffuse bone contour. And you know what I'm talking about. We're going to look at those pretty quickly here. See that bone being tense? This is what I mean here. Sometimes we take the patient back and we look at the CBCT right after the graft, and it looks like this, kind of this diffuse, sloppy placement of the bone. That's not going to work 70, 80% of the time. I'm telling you, your bone's not going to take. You can tell just by looking at these cross sections that the bone is not condensed firmly. It's not condensed properly. It's not fixated well enough. And that's why these cases, if you see this on your post-op CBCT, that's why those cases just don't work very well, as opposed to the cases where you see the beautiful situations on initial post-op. You can see we track these cases A, B, C, D. We look at the initial post-op, then we look at the 6-month follow-up. We just got almost the same exact results following 6 months as when we placed the graft. So we got really nice results, and we followed these patients. We did a little study in our office following 37 horizontal augmentation cases. And we took the cross sections immediately after and at 6 months. And what we saw was that 18 out of the 20 sites showed horizontal bone volumes within 1.5 millimeters of what we started with in the cases that had that defined dome, that defined condensed bone dome that we created, versus the other group that did not have that defined dome, really did not have as successful results. So by placing this membrane in the fashion where we can aggressively condense the bone, we can create that condensed dome-like bone contour that's going to allow a great result down the road. Okay, so now we've placed our bone. Let's go back there. We've placed our membrane, placed the bone. You can see on the right collagen membrane there that's going to get ready and lap over from over the crest over to the lingual. And these were the results at 4 months. This was a 4-month CBCT. Look, the same dome that we had when we started. I don't have the x-rays from immediately post-op here, but the same bone we started with is what we're finishing up with now going into the implant placement. So really nice results when we have that situation. You can see here the results. Just excellent bone volume, really nice buccal bone volume there that's going to really house those implants for a long time. Here's another case. You saw this early on. I was showing this as an example. We're using the PTFE membrane, the autogenous bone, allograft, xenograft with autogenous, native collagen membrane over, the Profix screws, the glycolon sutures for periosteal cinching. This case, we did use a little fibrin from the PRF, mixed it all together. I've used different techniques for playing around with putting that collagen membrane over, but really, if you just drape it over and cinch it down with some periosteal sutures, you get some good results. Now, we've got to close over this. I'm not going to spend a lot of time with this, but we know we've got to get good periosteal release. We've got to get good primary closure. This is something that we know so much, but we don't always execute well. We've got to get great passive closure over our graft site. I'm just going to go over this very quickly. On the lingual, we get that mylohyoid stretch, get that muscle to stretch there. You can see using a blunt instrument there, especially on the posterior. We're using a blunt instrument there to really stretch that out. When you get closer to that zone of the bicuspids, you can actually use, I'm going to quickly go over this, you can actually use a blade to make a small incision into the periosteum, because a lot of times we get the exposure at the mesial because we don't have that stretch of the mylohyoid as much on the mesial side of our graft. So we can be careful here. We know the lingual nerve is going to dive down once it passes that second molar. So we got a little wiggle room here to use a blade to get some release of this tissue, but we really want nice closure. I like to use 2 layers of horizontal mattress sutures to me, and I like to use glycolon sutures nowadays for this, because these are the sutures that are uncomfortable for the patients to take out. You know that. You got to pull them. You got to have your assistant retract. You got to pull these sutures out a bit. This is uncomfortable. So if you use those glycolon sutures, and I do 2 layers, I get more of a flap inversion. When I don't just do 1 layer, I do 2 layers and really get a nice inversion of that flap. And then sometimes I'll close with glycolon, sometimes I'll close with PTFE, and we still get nice results. You can see on this case, another case here, we've got the screws here, the Profix screws in place, the bones in place. And when we come back in, we're going in for PTFE removal. This is at 6 months. We come back in. Sometimes that PTFE can get kind of wrangled in the periosteum a little bit, but we kind of get that out. And you can see us getting the Profix screws out here. Now, if the Profix screws are engulfed in bone, we just leave them in. But if I can see them, get to them easily, yeah, we'll take those out real nicely. And then this is what we're coming in at. This is what we want to see here. When I've done all this work, when I've used all these biomaterials, when I've sweat, making sure the patient is healing right, when I go back in to place the implants, this is what I want to see. And if you look at the buccal of this video, that's where you can see exactly where the PTFE was. You see that contour of where the PTFE was. And I want to show you that contour on just a couple more cases here. This case, we already grafted the left side. Now we're going to the right side here. So we're going ahead and get rid of that bridge. This is our pre-op. In 6 months, we see that nice dome. But I really want to just go to the video here of what it looked like when we went in to place the implants. You can see, I wish I had put that PTFE a little more mesial. You see the bone a little more thin mesial, but you can see where that mini-me is showing right there, where the PTFE was. You know exactly where the PTFE was. It's quite magical when you see this and you know exactly where the PTFE was and the effects of that on the horizontal volume there. Really nice results, no exposures, no real risk. Very rare you get an exposure. I'll show you one case. One thing I like on these large grafts, whether it's this technique or another technique, when you're placing your healing abutment, if you haven't already profiled the bone to place the implant, I always like to do some bone profiling before I put my healing abutment. To me, I see that when you're placing the healing abutment, you get some resistance to it. This is a little pro tip just on implant placement. You get a little resistance to that healing abutment. That can cause some bone necrosis right at the crest there. So before I put my healing abutments in, especially on these large grafts, I like to do a little bone profiling there just to make sure that my healing abutment goes in really passively with no issues. And then we're going to finish up here. We can see another case. This was at the time of extraction here. So we see the time of extraction. We put the bone net in place. We're going to go through this quickly. Really nice healing here. Go ahead and came in at 6 months and just look at that. You can see exactly where the PTFE was placed. We didn't need the PTFE further. Posterior bone was pretty good there, but this is done with an extraction. We did basically a bridge pres with extra augmentation so that we could get nice results. Took the PTFE membrane out. We get these great results here, get the implants in, and you can feel confident about these implants. You can feel confident that they're going to last quite a long time. Again, there you can see the PTFE in place and then the result. So really nice result on this case. Do we ever get exposures? Yeah, very rarely, but you can see here, if you look at the x-ray, one of the Profix screws came loose. Obviously, I didn't put it in tight enough, came loose. That's going to create some mobility. Anytime that PTFE has more mobility, it can get exposed. But I tell you what, I took this membrane out, I waited, and even though that membrane got exposed, I still got a great result. I still got a really nice result from my graft. I didn't have to go back in and contour graft. I got a really beautiful result. Finally, just last case here, you can see the Profix screws in place. You can see where they're put. You can see where the graft is put there. Really nice fixation of that membrane. And this is what it was at 6 months. We can see you can see where the PTFE is. This one didn't get engulfed in the periosteum, so we could take that out nice and easy. And really, this is the home run. This is the type of thing we want to see. This is what you go home, you call your friends about, you call your colleagues, and you say, hey, look what I did. You posted on Instagram. You're so happy. But really, for me, it's just I want to be able to replicate augmentation technique daily on my patients to make sure I'm giving them results that are predictable. So we took 29 of these cases and we followed them, these apically supported PTFE membrane with all the parameters we talked about. 26 out of the 29 cases had just beyond great results, averaging 3.84. We really got great results on these graphs. And like I said, the headaches were much less. The procedure time was much less. And one thing I always learned was that, and this is in the OR, in our offices, the longer the procedure, if you're hammering away for 3 hours on an augmentation, your chances of infection just shoot up. So the shorter the case can be, the less chance of infections. It just really makes it easy for the patient, for everybody involved. I always like to say, as an implant surgeon, as a regenerative surgeon, my day is always about avoiding complications. So for me, I'm a big Bono fan. Being insecure, sometimes I say you have to be a little insecure going to every case. You have to know that there's going to be problems around the corner. You got to stay humble. Somebody asked Bono, how does he keep creating new music over and over? And he said, insecurity is the best security. And all he meant was, you got to stay on your toes. You get overconfident, it's going to bite you in the you-know-what. So thank you very much. Eric, any questions?
Hey, thank you, Dr. Wardani. That was some great information. Yeah, we've got a lot of questions that have come in. So now it's time for the Q&A portion of the webinar. Again, reminder to everybody watching, we'd love to hear from you. The Q&A button is at the top right of your screen. But like I said, we've already got quite a few that have come in, and I'm going to try to go through these and, sort them out as best I can. When first one's about sutures, and let's say both with the ridge preservation cases that you showed, along with the larger augmentation cases, when are you removing the sutures when you use the PTFE sutures?
Good question. So on a ridge anytime I'm using the PTFE as some form of bridge preservation or leaving the socket open without primary closure, I tell the patients coming back twice. Unfortunately, they're having to come back and see me twice. I bring them back at 2 weeks to take out the sutures. Okay. The reason I do that, I love PTFE sutures. It's really a lot of my go-to sutures, unless I'm leaving it in like the glycolon sutures. But for those ridge spreads, I love PTFE. But whether it's PTFE suture or another suture, in the presence of saliva in a non-primary closed situation, those sutures get loose. And patients like to cut them themselves. And I don't want them to cut it themselves. They cut it themselves. They pull out the membrane with it. They say, oh, no, doc, I'm a nurse. I know how to do this. It's crap. They're going to ruin my graft, even if it's a basic graft. So I have them come in at 2 weeks. I take out the sutures and I bring them back at 4 weeks to take out the membrane.
Okay, that's a good plan if they're doing that.
And always
are you
take out the sutures yourself? That's a big deal. Go ahead.
I'm sure they always listen though, right?
Never. Go ahead, Eric.
Are you taking a CBCT prior to extraction to try and predict the defect size? And then kind of the second part of this question is, do you go over the cost of the different technique options during treatment planning?
Yeah, good question. So if it's if I don't see a huge apical lucency, then no, I typically won't take a CBCT on that visit. If it's a basic socket graft, now if I'm taking a tooth out because the referring dentist is curious about a fracture, yeah, we'll take a CBCT to evaluate that situation. I can't say I take a CBCT on every single extraction case. Typically, because I know I'm going to take a CBCT later before the time of implant placement. For my larger grafts, I always take a CBCT before and after the graft, and again before implant placement. But on a basic extraction, if I don't see any major issue going on that I need to worry about, then I'm just going off of a PA. And in terms of the cost, I really build my costs in. I'm very fair with my patient, but if I'm placing an implant, they're almost always going to be treatment planned a contour augmentation after the fact. Now, I don't always need it, but that's one of the things I see is that you place the implant, you still need a little more bone volume. They're not aware that you need extra bone. You're using biomaterial, you're paying money for it. That's where it gets murky. So yeah, I mean, every graft I do, if it's a socket graft, it's one price. If it's a socket graft with a defect, yeah, it's a little bit more. I know I'm using more biomaterial. If it's a horizontal aug, it's going to be more. If it's a lateral sinus, it's going to be more. I really try to gauge my biomaterial and then relate it to the cost of the procedure.
Okay. How does your technique differ when you're securing the titanium reinforced PTFE or the RPM versus when you're using collagen membranes doing like the sausage technique?
I would say, in my hands, if I'm doing the sausage technique, then I am using tacks. I am hammering tacks in. Versus if I'm using an RPM or a tie reinforced PTFE, I'm using Profix screws. That's really the only difference in those techniques is using tacks versus screw. And of course, the membrane, collagen versus the tie reinforced PTFE. But it's the same amount of primary closure I need. It's the same issue I need. I will say this. If I'm using PTFE over the crest, high reinforced, then I am very hypercritical of the soft tissue thickness. Sometimes I'll go in and I'll thicken the soft tissue even months before the graft. And I'm very critical of patient's health. If patient isn't quite healthy, I'm not going to do some of these larger grafts.
Okay. On the case that you showed with the anterior implants that had the bone loss, what was the technique you used for cleaning those implants? And then what kind of a bone graft mixture did you use on that case?
Yeah, so that kind of that Hail Mary case. We disinfected, we decontaminated those the surfaces. Titanium brush, used a Straumann titanium brush, and citric acid, tetracycline, and that's how we really decontaminated those surfaces. And then we used autogenous bone and a combination again of xenograft and allograft.
Okay. In the bone net technique that you were showing, are you using native or are you using cross-link membranes?
No, that's a native collagen membrane. Yeah, that's a native collagen membrane.
Okay, and then do you ever use the titanium reinforced PTFE, or do you find that the non-reinforced PTFE works well for that?
Yeah, the non-reinforced is fine because, like I said, if you're using that titanium reinforcement is basically giving a contour stability. It's giving a volume stability. That's going to be more for a vertical graft. Okay, if I'm doing horizontal, which is really my day to day, if I'm doing a vertical, I'm going to use a tie mesh or a titanium reinforced. But if I'm doing horizontal, you don't need that titanium reinforcement. That membrane is pretty much just going to be held with the bone inside of it. It's going to hold its contour. So yeah, definitely not titanium reinforced.
Okay. Well, that was fantastic. That's about all the time we have for the Q&A. But I just want to thank everybody for watching. We hope that you enjoyed the webinar. And just a reminder that a feedback survey is going to be sent out shortly. And once you complete the survey, you'll be sent your CE certificate after that. So again, thanks so much for everyone watching. Dr. Wardani, thank you so much for your time tonight. Great information, really enjoyable. Appreciate having you on.
Thanks. Appreciate it, Eric. I'll hope to talk to you soon. Thank you very much.
Sure. Thank you, everybody.